Tēnā koe, Mr. Chair, tēnā koutou committee members, for Siobhan tōku ingoa, he uri ahau no ngā puhi me ngā tihine me ingarangi me airangi hoki, he te noho ahau ki Tamaki Makaurau, ki te mahi ahau I kaupapa ki te Mental Health Foundation. I'm here today with Olivia Stapleton, and we're part of the Policy and Advocacy team at the Mental Health Foundation of New Zealand. So you'll know from our submission that we do think this bill will make Aotearoa's mental health system slightly better, but we're disappointed that it doesn't deliver the transformation initially promised. This really was an opportunity for us to be brave and innovative. It was our chance to truly listen to what tangata whaiora have been telling us over and over, to do what 20-year-old human rights conventions have been asking of us, and what inquiry after inquiry has been asking of us. Instead, unfortunately, we've chosen to just stretch the status quo a little bit, but I hope today we can provide some suggestions on how to stretch it a little bit further. Starting with the human rights, our mental health law engages lots of our domestic and international commitments. A particularly relevant one is the UN Convention of the Rights of Persons with Disabilities, the CRPD, which New Zealand ratified in 2008. A key element of the CRPD is its affirmation of the right to legal capacity. People with disabilities, including psychosocial disabilities and mental distress, have rights and duties equal to others and should be able to exercise them on an equal basis with others in all aspects of their lives, including within the context of mental health care. This is true even when people's decision-making is affected by mental distress. So with this in mind, I'm going to talk about a few of our suggestions for making the bill more rights-based. The first thing we suggest is that you consider dividing the bill into separate civil and forensic criminal justice pathways. This would allow the civil process to eventually integrate into a generic framework for decision-making capacity, which the Law Commission is currently considering. Splitting the bill in this way would help avoid the question of unjustified discrimination on the basis of mental distress, which the CRPD raises, and on a practical level would be more coherent and less complex. Other submitters have raised concerns about the difficulties imposed by the bill's capacity assessment. Think about how difficult it's going to be for practitioners to determine that lack of decision-making capacity is purely down to someone's mental distress. A generic approach would avoid having to squeeze into such boxes. Moving the civil mental health provisions away from the forensic or criminal justice pathway would also discourage untrue yet persistent public attitudes that label people experiencing mental distress as dangerous and in need of a risk-averse, restrictive response. We're aware that similar recommendations about generic capacity law have been made by other submitters, including health and disability law specialist Eris Rovekamp, academic and consultant psychiatrist Giles Nugent-Howes, lived experience-led Changing Minds Trust, Te Herenga Mahara, the Mental Health and Wellbeing Commission, and the Human Rights Commission. The second thing we recommend is for this bill to explicitly reference the CRPD. This will provide a clear signal to the courts and people fulfilling statutory roles under the Future Act that they should seek consistency with the CRPD as far as possible. We also think it's a good idea to reference other International Human Rights Commission human rights treaties we're a party to. Our third recommendation for making the bill more rights-based is to add tangible measures to reduce the use of compulsory treatment outright. We are incredibly concerned that this bill will not make a radical difference to the rate of compulsory mental health treatment or its hugely inequitable use on Māori and Pacifica. Yet reducing compulsory treatment has been continually named as a fundamental goal of this law reform. One suggestion we have to meet this goal is to greatly reduce and potentially end community treatment. We understand that community treatment orders are often used as a way to enable better access to care, such as when someone has recently been discharged from hospital. But we should not be responding to systemic issues in access with unnecessary and prolonged coercion, which infringes on people's rights and erodes trusting therapeutic relationships. Instead, we should be properly planning and resourcing the delivery of a functional voluntary system. We think there's merit in exploring alternatives to compulsory community treatment, such as Te Kete Rongomo's suggestion of a community care contract, and in learning from international initiatives to provide wraparound community-based voluntary care grounded in principles of collaboration and supported decision-making. Our fourth recommendation for better human rights alignment is that this bill needs to include a sunset clause for seclusion. Seclusion or solitary confinement has been denounced as a form of torture by human rights bodies, and this bill is our chance to finally draw a line in the sand. If we've learned anything from the victims and survivors of the Abuse and Care Inquiry, the numerous harrowing investigations into seclusion, we must end it now. We understand there are resourcing requirements to enable its elimination, but we think that a sunset clause prohibiting its use after a specified period of time would apply pressure on the sector to provide for these conditions. We don't believe zero seclusion will ever be achieved without clear legal prohibition and parallel funding, prioritization, and leadership. The fifth and final thing I'm going to say about human rights is that there needs to be a standalone clause requiring the bill to give effect to Te Tiriti o Waitangi, or clause 5 needs to be amended to create a stronger and clearer directive that ensures the bill as a whole will give effect to Te Tiriti. This is a necessary part of acknowledging and protecting the rights of Māori. It's in step with contemporary health policy making, and it's essential to enabling culturally relevant supports for Māori and reducing inequities. Like other submitters, we agree that redrafting and implementing the bill to give effect to Te Tiriti must be undertaken in partnership with tangata whenua. A final general comment I'm going to make is that we see this bill as both not transformative enough and at the same time overselling its potential to be transformative given resource constraints. This could lead to unmet expectations and disappointment, as was the case with some aspects of the 1992 reforms. It's therefore crucial that this new legislation is supported by adequate changes in practice, service structures, resourcing, and workforce development. For that reason, we recommend the Ministry of Health be directed to demonstrate how it will support the shifts needed to achieve a reduction in compulsory care in a detailed implementation plan, and for the 5-yearly reviews to impose recommendations on the Minister responsible for mental health. If implemented well, this bill does have the potential to bring us closer to the mental health system we all aspire to. Thank you.
Excellent. Thank you very much for your submission. I don't see any hands up for any questions, but Tracy has a hand up. So Tracy, time for a quick question.
Okay, just really quickly, thank you, Mr. Chair, and thank you both Siobhan and Olivia. That was an excellent submission. You talked about the community or compulsory community orders and care. In your submission, you've obviously got some more detail. Are there really good examples of, I'm assuming, where this is done much better elsewhere?
So one of the examples we've given in the oral submission today is this idea of the community care contract, which was put forward by Te Kiti Rangamo. That's just one example where, you know, the reason that community treatment orders are often used is so that people being discharged retain that kind of VIP status and level of care in the community that voluntary patients don't have access to. So we think there's merit in ideas like that, where the responsibility stays on the services to provide that level of care and a responsibility to continue to stay in contact with tangata whai ora without the compulsion aspect being applied to the person. There's a lot of international examples of alternatives to compulsory treatment being trialled elsewhere, and even approaches being used in New Zealand that we would just be looking to scale up. So there's some, like, you know, kaupapa Māori approaches. There's what happened in Trieste, Italy. There, you know, Denmark, for example, has managed to avoid using seclusion. There's quite a lot of stuff out there. Olivia might have something else to add.
Or we probably do need to move on, but thank you very much for your submission. Really appreciate taking the time to come and submit to us. So thank you.